Ladies and gentlemen, thank you very much for attending the APA-SL 2024, the Center of Hepatology. Now we would like to start our conference program. Now we start the session. HCV Elimination Policy Forum 2024. Dr. John Ward, please.
Thank you. It's good to open this Hepatitis C Policy Forum. It's great to get together, share lessons learned about what is working to advance our progress toward elimination, what are the challenges, and how we can work together to overcome them. And that's the whole purpose of APOSL. That's the whole purpose of the Coalition for Global Hepatitis Elimination. And that's why we're working together to convene this policy forum. We have a very robust schedule of speakers. We have ample time for discussion, and we look forward to having a real interchange of our experiences and our ways forward. This is our agenda. You'll be hearing from Professor Kato in just a moment. We'll be having a video message from the Minister of Health of Japan, followed by comments from Philippa Easterbrook and myself to set the stage for some presentations on particular aspects of how to deliver hepatitis C testing and treatment services for various populations, whether they be for persons with substance abuse disorders, persons with diabetes, general population strategies, the importance of policies to direct and scale up hepatitis C testing, and then having a discussion where leading to a call to action that I'll be describing more in a moment. As part of our opening, I will turn it now over to Professor Naoya Kato, Professor and Chair of Department of Gastroenterology, Graduate School of Medicine at the Chiba University here in Japan. Thank you.
Thank you, Professor Ward, for kind introduction. And slide, please. My slide, please. Good afternoon, everyone. And this HCV Elimination Policy Forum, I'd like to give opening remarks. As you know, this is key factor of hepatitis C. HCV can cause both acute and chronic hepatitis, and also lifelong illness, including liver cirrhosis and liver cancer. And HCV is a blood-borne virus, and most infection occurs through exposure to blood from unsafe injection and unsafe health care and screening blood transfusions, and importantly, injection drug use, and also sexual practices that lead to exposure to blood. And globally, an estimated 58 million people have chronic HCV infection, with about 1.5 million new infections occurring per year. And WHO estimated that in 2019, approximately 300,000 people died from hepatitis C, mostly from cirrhosis and liver cancer. And DAAs can cure more than 95% of patients with HCV infection, but access to diagnosis and treatment is unfortunately low. And there is currently no effective vaccine against HCV. And this slide shows the HCV infection in the world and also Southeast Asia in 2015. This Southeast Asia region, around 0.5% of people are infected with HCV, namely 10 million persons are living with HCV, and still 300,000 persons are newly infected by HCV annually. So between 2015 and 2030, WHO targets include reducing new HCV infection by 80%, and also reducing HCV deaths by 65%, and increasing HCV diagnosis from less than 5% to 90%, and the number of eligible persons receiving HCV treatment from less than 1% to 80%. This slide shows the cascade of care for HCV infection by WHO region 2015. About 71 million people are infected, and this part is Southeast Asia region. And the 2030 target, 90% infected diagnosed, but now only this part is diagnosed, but more than 70% is undiagnosed. In the 2030 target of WHO, 80% of diagnosed treated, but still only small percentage of patients are treated and also cured. So we have a good DAAs. So now the DAAs become pangenotypic and very effective. No live wiring required, and also minimal pre-treatment assessment, and also high barrier to resistance. And short duration, 8 to 12 weeks is enough. And once daily dosing, and minimal or no on-treatment monitoring, and easy to manage drug-drug interactions. So I final message is moderated from CGHE homepage to avoid the dire consequences of inaction. It's a time for all countries to accelerate steps to eliminate hepatitis C. Thank you for your attention.
Thank you. Thank you very much. Excellent comments, setting the stage for our discussion. I think it's also our privilege to introduce a video message from the Minister of Health, Kizo Takimi. So let's hear from the minister.
皆さん、こんにちは。参議院議員の武見敬三です。本日、第33回アジア太平洋肝臓学会年次総会にご出席の皆様には、日頃から肝臓疾患に関する基礎的、臨床的研究を奨励し、肝臓学の向上や社会の福祉増進に大きく貢献いただいていることに、心から敬意を表します。我が国には、肝炎ウイルスに感染し、あるいは肝炎に罹患した方が多数存在し、国内最大級の感染症となっています。これまで医療の進歩、医学的知見の積み重ね、科学技術の進展により、肝炎の克服に向けた道筋が開かれてきました。我が国においては、血液凝固因子製剤に C 型肝炎ウイルスが混入することによって、特定多数の方に感染被害が生じたこと、また集団予防接種の際の注射器の連続使用によって B 型肝炎ウイルスの感染被害を出したという歴史があります。このような現状において、肝炎ウイルスの感染者および肝炎患者の人権を尊重しつつ、良質かつ適切な医療提供を確保することなど、肝炎の克服に向けた取り組みを進めてきたところです。我が国では平成22年に肝炎対策基本法が施行され、この法律に基づき制定された肝炎対策基本方針により、肝炎ウイルス検査、肝炎医療、研究、普及、 啓発などの肝炎の総合的な対策を進めてまいりました。近年では、水型肝炎のインターフェロンフリー治療薬の開発により、高い確率でウイルスの排除が可能となり、平成20年に開始した肝炎の治療に対する医療費助成について、平成26年からはインターフェロンフリー治療も対象とするなど、助成の対象を拡充してまいりました。慢性肝炎、肝硬変を背景に発症する肝がんの成因は、1990年代全般までは、C 型肝炎ウイルス感染に起因するものが7割を占めていましたが、こうした取り組みの結果、その後はその比率が減少をし、肝がん死亡者数、罹患者数も減少傾向にあります。世界保健機関の2016年の総会で、2030年までに公衆衛生上の脅威としての肝炎ウイルスの排除達成という目標が掲げられました。このような中で、とりわけ C 型肝炎ウイルスについては、各国が WHO の掲げる目標の達成に向けて取り組んでいるものと承知をしています。我が国においても引き続き、肝炎総合対策を進めていくことにより、肝炎の克服に向けて取り組んでまいりますので、本日お集まりの皆様の変わらぬご尽力を心よりお願いを申し上げます。結びといたしまして、当会のご成功と、本日ご参加の皆様のますますのご発展を記念申し上げ、私の挨拶とさせていただきます。厚生労働大臣、武見敬三でございます。
Thank you very much. I'll now turn it over to Professor Cato to moderate the first session.
Okay, I'd like to start our first session, updates on progress towards HCV elimination. And the first speaker is Dr. Philippa Isabrook. She's senior scientist, Global Hepatitis Program, Global HIV, Hepatitis and STIs Program, World Health Organization, Switzerland. So her topic is status of HCV elimination globally and in Asia. So, Dr. Isabrook, please.
Thank you very much, and thank you for the opportunity to speak at this session. And so, in this short presentation, I think my role is really to set the scene and to provide a global perspective from the WHO angle, and looking at some of the activities and the products and the guidance that have come from WHO, and some of the new products that are coming soon, which it's important for you to be aware of. So I will be touching on the global strategies, the global progress report, which is coming soon, the new strategic information guidelines coming soon, and then to spend a little time on our guidance for countries on validation for the elimination of viral hepatitis B and C as a public health threat. And there was an update to this in the last year. And again, it's something we very much want to promote and encourage countries to submit. And then to finish with a summary of the hepatitis C guidelines for simplified care that were published in 2022, just to remind you of the key messages. So to begin at the beginning, and the minister has already alluded to where it really started in 2016 in terms of WHO engagement with the first global strategy for viral hepatitis B and C, which set ambitious targets towards elimination of both viral hepatitis B and C as public health threats. And this was based on particularly modeling work, which demonstrated that through the scale up of 6 synergistic preventative interventions, as well as testing and treatment, that elimination was indeed feasible and set out those targets for program targets in order to achieve the impact targets for elimination, with the 65% reduction in mortality, 90% reduction in incidence. Well, since then, there's been a new strategy, and this was an integrated strategy for both HIV, viral hepatitis, and STIs. And that reflected the merger and acquisition of the HIV program at WHO, which brought in hepatitis and brought in STIs. And this really strategy played to the synergies across those diseases, as well as some of the distinct features. So there were 5 strategic directions. And I think just to highlight, it's shown in the green box, the particular challenges and particular shifts required if we're to achieve elimination of viral hepatitis. And that really included promoting much greater public awareness in the community, as well as among healthcare workers, as well as political advocacy, the importance, the absolutely critical importance of community and civil society engagement, the need for scaling up for hepatitis B, access to birth dose, which is indeed now happening, and promoting the increased access to the testing and treatment, a simplified care model with decentralization as well as integration of services, and the issue of financial resources being allocated at a national level. And I think this slide really just summarizes those same messages, but put into a framework of the key inputs and interventions needed, what the particular outputs and outcomes would be, and the key impact, which is ultimately to achieve the end of AIDS, as well as the epidemics of viral hepatitis and STIs. And this is a table which summarizes and outlined in red are the targets for hepatitis C, that presents the targets for 2025 and for 2030, both in terms of the percent reduction. The original metrics were relative reduction, as well as relating that to the absolute targets for both new infections, the incidence, the mortality, as well as the program targets for testing coverage, treatment coverage, and for the main preventative interventions. So we published in 2021 the Global Progress Report, and that was based on data available up to the end of 2019. And that's what's shown on this slide. And on the right, showing the cascade data for both B and C, which you saw in the earlier presentation. In a week's time, there will be new data, both in terms of global burden and in cascade data and by region. And unfortunately, I had to change the slides because they're in fact embargoed until the 8th or 9th of April. But I think I can certainly share that for hepatitis C, there's a further reduction in the burden, as you would expect, relating to the significant and sustained scale up of treatment, although that's more in certain regions where that's happened. And in terms of the cascade data, again, a continued improvement in coverage of testing and treatment. Hepatitis B, though, continues to fall significantly behind the progress with hepatitis C. So what else is coming? Well, I'm going to mention in a few slides about the updated guidance for country validation of viral hepatitis elimination, shown on the left. That came out about a year ago. There's now a new framework for a really important initiative of WHO, which is the triple elimination of mother-to-child transmission, HIV, hepatitis B, and syphilis. We're doing a lot of work in this area to promote that. There's going to be the new hepatitis B guidelines, which I will be presenting and launching on Saturday in this room at 10:50. And then I've mentioned the Global Progress Report, which will be launched at the Viral Hepatitis Summit in Lisbon in about a week's time. And there's also going to be consolidated guidelines for strategic information for viral hepatitis that's coming soon. So I'm just going to mention about the elimination guidance. So these were first published in 2021, and guidance for pursuing elimination for hepatitis C, hepatitis B, as well as mother-to-child transmission, so different options for countries. And then this was further updated with some significant changes. And I've actually been to a couple of presentations already where I have noted that people are still showing the table of the key metrics for validation that were from the original guidance. So it's important you're aware, and this table is a summary of that, of the all the impact targets, that's incidence and mortality, and the program targets for B, and on the right for C. And the main difference with C now is that, well, both B and C mortality is we've combined the mortality target. So it was less than 2 per 100,000 for C, and it was less than 6 for hepatitis B. And now we've combined those. So it's overall less than 6 per 100,000. And the incidence target remains the same. So next slide. We did some country pilots before we updated the guidance from a range of countries. And I think some helpful and not unsurprising feedback that measuring incidence, particularly in relatively low prevalence areas, can be challenging to demonstrate you've met that metric. And the general strategy is to retest the negatives in order to get your estimate of incidence. In terms of mortality, particularly in low and middle income countries, not surprisingly, it's recognized that death certificates in cancer registry often fail to capture hepatitis B and C as an underlying cause of death. And so a strategy we've been promoting is using sequelae surveillance, and many countries are now doing this. So with cases of cirrhosis or HCC, being able to attribute what proportion are due to B or C, and this can be used in projection of really liver-related mortality. So one thing that is new in the updated guidance is that we now have a path to elimination. And this path to elimination, rather like the Olympic medals, there's a gold, a silver, and a bronze. And this is really to recognize those countries that may have very high burden, that are making important progress in their programs, but are still some way off achieving those mortality, in particular mortality targets, recognizing it's often a 20-year lag between scaling up treatment and showing an impact on mortality. So these are program targets alone, with incremental percentage coverage from bronze, silver to gold, in order to be able to recognize the great responses that have been made in some countries. And I think it was a wonderful moment when we were able in October to award Egypt as the first country to receive the WHO Gold Tier for hepatitis elimination, and the Director General came with us and presented to President al-Sisi. And in fact, we won our own small award for being part of a 3-level WHO response to support the country in achieving that goal. So what will it take to achieve elimination? I think this is just another simplified framework of really all the good practices that really we're encouraging countries to adopt, to have that holistic approach in their response, covering political leadership, the strategic planning, the driving down prices of drugs and diagnostics to promote access, and simplified service delivery. And I think on the right is just the very nice framework that the Clinton Health Access Initiative uses to approaches to building a hepatitis public sector response. So I'm just going to finish with a few slides to remind you of our key messages on the simplified service delivery diagnostic innovations for the Hep C response. And so just as with HIV, there's been a continued evolution and progressive simplification of our guidelines, and with the adoption, obviously, of a treat all pan-genotypic regimens, and then simplifying to 3 preferred regimens of Daxophel and GP, and expanding treatment to down the age groups, first to include adolescents, and then in 2022 down to 2 to 3 years. And then we initially had good practice principles for simplified service delivery, but with the growing evidence, we're able to issue formal recommendations for decentralization and task sharing. And similarly, on the diagnostic side, with the use of a point-of-care viral load assay as an alternative to lab-based and reflex viral load testing. So these were the recommendations for children, reconciling the same regimens that have been proposed for adults for use in adolescents and children. I think the major challenge we're facing is really a systematic approach to case finding to enable these children to benefit from treatment before they become sick. So particularly ensuring that all children, the offspring of Hep C positive parents, are tested. In terms of the service delivery, the main messages being we recommend both the testing and the treatment can be done at peripheral health or community-based facilities, and ideally at the same site for the testing and treatment. And this could be primary care, harm reduction sites, prison ART, as well as in the community, and to integrate. So where you are decentralizing, to integrate the Hep C testing and treatment as part of existing services, including harm reduction measures. And for task sharing, recommending delivery of testing and treatment by non-specialist doctors and nurses who've been trained. Clearly, many implementation considerations. And not every country is going to wish to decentralize, and the decentralization and simplified service delivery needs to happen alongside all the other community engagement, efficient procurement, and supply chain. Task sharing clearly requires the appropriate training and mentorship, and ideally within the framework of a differentiated care model, just like with HIV. Those who are well and stable can absolutely be managed at the peripheral health sites. In terms of the diagnostics, the main recommendations, the ones on the left are the 2017 testing recommendations. And really, we are now promoting hepatitis C self-testing. And as I mentioned, the point-of-care viral load for both detection of viremia and test of cure, use of dried blood spots as appropriate, and reflex testing. Implementation considerations, again, national programs need to look at what would be the strategic positioning, where the point of care would best be used versus the laboratory-based, and with a particular priority for those sites where there's maybe high loss to follow-up, harm reduction sites, persons who inject drugs, where fast tracking of the diagnosis. And the ultimate placement for the point of care instrument is where testing and treatment are at the same site, a one-stop shop. And we've been able to demonstrate from testing to treatment can be a matter of a couple of hours. And the opportunity, of course, to integrate using multi-disease platforms. And with reflex testing, same applies. It can be laboratory based if that's where your serologic testing is done in a lab, and immediately reflexing a positive result to the use of doing viral load. And I think just as an advance notice, we're adopting the same simplification approach with the new hepatitis B guidelines on the who to treat, the antiviral regimens, the antiviral prophylaxis, simplifying diagnosis, simplifying service delivery. This is a quick look at the shift in the algorithm where we're substantially expanding the proportion of Hep B surface antigen positive who will be eligible compared to previously. To thank my many colleagues and to also just leave up the slide on the session for Saturday. So please do attend, and looking forward to your feedback. Thank you.
Thank you, Dr. Eastbrook. And the next speaker is Professor John Ward, and he's a director and coalition for global hepatitis elimination. So, Professor John Ward, please. His topics is national advances towards HCV elimination in Asia.
Great. Thank you. Thank you again. I want to thank Philippa for setting that stage and really describing WHO's really excellent efforts of providing a framework for quality of delivery of the services needed to eliminate hepatitis. What I'll be doing is now shifting our focus more toward a national level and what's going on here in Asia before we take that next step and learn from at the local level different options for delivering testing and treatment for hepatitis C. At the US CDC, we used to say all public health is local, and I believe that's true for hepatitis C elimination, and we'll be seeking to progress from the global to the national to the local. These are my disclosures. Again, I'll be looking at different what's going on at the national level here in Asia, and the importance of working together in that regard. As was touched on by Professor Cato, we have about 58 million people living with hepatitis C globally. About half of those are living in countries of the Southeast Asia and Western Pacific region of WHO. About 40% of the mortality globally are in countries of Asia, and almost about 1 out of every 3 new infections are in the countries in these regions. So really a lot of good reasons to target hepatitis C for elimination. We can have a great health impact, again, in the countries of these 2 regions with preventing over 666,000 deaths, 8.4 million DALYs averted, preventing 2.8 million new infections by 2030. All of these interventions would be cost saving, and perhaps very important to governments. There is a consequence of inaction, of failure to eliminating hepatitis C and lost productivity from premature mortality and disability. And that can not only be reversed, but you can also get economic gains by seeking and achieving goals for hepatitis C elimination. And as was touched on by Professor Cato, we just put out a report on the consequences of inaction and how to overcome them. That's available on our website at globalhep.org. And I think there was one of the reasons that these economic consequences, one of the reasons that the G20 in their New Delhi declaration this past fall called out the need to continue to have progress toward ending hepatitis when they looked at coming together as an economic bodies. At the coalition, we really recognize from the experience of other disease elimination programs, particularly those that have been run by the Task Force for Global Health, where the coalition resides with their experience in polio, smallpox, measles, that there are key components that make disease elimination and hepatitis elimination programs effective. The good data to guide policy development, that can also help national planning, the engagement of political leaders, the pilot testing to tailor strategies, a focus on health equity, which is really the only way you can achieve goals for hepatitis elimination, is for everyone to benefit in the community or a province or a country. Integrating hepatitis services within existing health systems, so whereby hepatitis elimination is strengthening the health system as you move forward. Seeking financing so you can sustain your progress toward your goals or achieved. The importance of operational research to always look for ways that you can improve how you are conducting your activities. And hopefully we'll be learning some from our presentations to follow. And then having data to recognize when your goals have been achieved. You know, as part of that effort over the last 2 years or so, we have put together profiles of hepatitis elimination programs now in about 33 countries, including 12 here in Asia, as is noted in the map there on the left, with a profile underway for Australia and India as well. And this brings together the status of data, planning, policy development, program development, implementation of these key interventions to prevent, test, treat, and cure hepatitis C. And then in so doing, recognizing the achievements, the gaps, and important next steps. Again, this just, again, reemphasizes key data regarding the prevalence of hepatitis C in various countries and the variability therein. So again, emphasizing the importance of good quality data. This shows you for mortality data that's reported by the countries as well as Taiwan for these national hepatitis elimination profiles. 2 countries appear to be close to achieving the goal, or really have achieved the goal for mortality reductions for hepatitis. That's Japan and Korea, with three reporting, Chinese Taipei, Japan, and South Korea reporting declines in mortality since 2015. So we need greater mortality declines in the remainder of those countries to really accelerate progress toward hepatitis elimination. And with all that said, as Philippa touched on, we really have an issue with quality of data to guide our work. Incidence tracking is a real challenge for hepatitis C because of the silent nature, clinically silent nature of acute infections. Mortality data often does not include the cause of liver cancer or cirrhosis. So that's a particular challenge, and relatively few countries have systems in place to track the number of people tested and treated. So that's a key focus area, but I think it's also important for all of us when we look at data to be cognizant of those limitations and to delve in and see where that data is coming from. Is it coming from a national registry, a sero survey? Is it just modeled data, et cetera? Based on the data we do have, we have some improvements in access to hepatitis C screening and treatment, as shown here. We have some role models, such as Australia, for example, Chinese Taipei, that are achieving high rates. And we're going to learn a little bit more about about Taiwan here in a moment. But we have some work to do, and we cannot cure people if we're not testing them and linking them to care. Fortunately, many of the restrictions that were put in place years ago because of the concerns regarding the price of HCV medications have fallen away. A large global survey of countries that we were part of as a coalition, along with our colleagues at the Kirby Institute in Australia, that was released in Lancet GastroHep. It's online now, will be released formally in April. Shows that many countries have already dropped many of these restrictions, as shown here, although not all, with treatment copays continue to be onerous, particularly for low and middle income countries. And so there are some areas for improvement, but there has been improvement compared to when the curative era first began. We also need better access to safe injection equipment for persons who inject drugs. Now, fortunately, in Asia, as you can see here, a number of countries are achieving high rates of access to clean injection equipment, but more work needs to be done in that area to lower the rate of HCV infection among the population at highest risk, in combination with other harm reduction strategies as shown here. Now, Japan has been a role model with policies for broad access to hepatitis C testing, which we'll be hearing a little bit more about in a moment, and decreasing many of the barriers to access to testing and treatment over the years. That said, they still have only diagnosed about 44% of the people living with hepatitis C. So it's really important to continue to sustain your efforts until your goals are achieved, even as you have a very mature program. You know, it's great to hear the minister continue to express that commitment. Again, for Taiwan, has put in place many of the testing policies, such as universal access to testing, that really helps to make testing widely available and lowering many of the barriers to access to treatment and making treatment available at the primary care level and not just at the specialty level. We can't, as we think about countries doing well, we have to be cognizant also of the countries that are just beginning on this hepatitis C elimination journey, such as Vietnam, which has a national plan, is doing a fairly good job of making clean injection equipment available. It's doing pilot programs to see how to integrate hepatitis C testing and treatment in those programs, but it has some work to do to lower the cost of treatment as well as testing so that everyone in Vietnam can benefit from testing and treatment. Another excellent example of a national program is South Korea. They, as you can see there in the middle column, they have are moving toward a broad scale up of hepatitis C testing. They have again lowered, seeking to simplify access to testing and treatment by making it available at the primary care level, but they still have some work to do in providing harm reduction. And working with them to identify their key next steps. Those are listed here on the right, particularly with that focus on scaling up hepatitis C testing as part of their annual preventive medicine checkup. So, all of these components are important, but to really do a great job, you really have to really put those into action. That national commitment is really, really important. And that's why that message from the minister is so important, to show that national commitment that helps begin to put those policies into motion in a country like Japan. In that regard, we have put, over the last several years, working with the WHO office in New York, we started a UN group of friends to eliminate hepatitis. A group of friends in the UN is a way countries come together on issues of common concern. There had not been one for hepatitis elimination previously, so we started that in the September of 2022 at the UN General Assembly, and we repeated it in September of this past year. And it's my pleasure and honor to have the Nobel laureate Harvey Alter help us in that effort. This is him providing remarks, and we have others in the room who have been part of those events. And we are growing that group of friends. We now have over 41 countries that have expressed an interest in joining the group of friends, with Egypt, Chile, and Portugal serving in the leadership circle for that group of friends. In that regard, I wanted to play some comments from Dr. Youngmi Ji, Commissioner of the Korea Disease Control and Prevention Agency.
Republic of Korea stand ready to tirelessly work with the international community in our joint efforts for achieving the UN SDGs and WHO's goal of eliminating viral hepatitis. We are strongly committed to share our experiences and lessons learned in controlling viral hepatitis and key strategies with other member states.
That's what we want to have happen here, is not only to have a scale up within the country, but be open to sharing your expertise and perhaps your resources with others, so we can truly have a global community working together to achieve these goals for hepatitis elimination. At the end of this session, we're going to have a call to action that I would like all of you, frankly, to sign. I'll be presenting it at the end of the program. Please stay around for that, because I think we need to show that evidence of a global community coming together in Asia, where hepatitis C is such a major problem, and there's so much to gain in economies and in health by achieving goals for hepatitis C elimination. So please stay and join me in signing this call to action at the end of the program. Thank you very much.
Thank you, Dr. Ward, for excellent presentation. And now the time to wrap up this first session. So I'd like to pass the chair to Professor Tanaka. Professor Tanaka, please.
Okay. Okay, ladies and gentlemen, my name is Junko Tanaka, Executive Vice President of the Hiroshima University. I am in charge in the PI of the research group under the Ministry of Health Japan. So this session, we will introduce two speakers of the Professor Grace Wong and Professor Yang Queen Chao, right? And this session is HCV elimination initiatives to reach marginalized communities in Asia Pacific countries. As the previous session, we of course understand that the HCV elimination is going on owing to the developed very good DAA treatment or something. But we have some issues remained in the marginalized communities, how to treat them and how to make them a good link of care. So this session, they will give a good speech from their specialized. So I'd like to introduce Professor Grace Wong. So she is a professor of the Chinese University of Hong Kong, and her research interested including big data research in hepatology, chronic viral hepatitis, and risk reduction of hepatocellular carcinoma. Okay, let you start. Thank you.
Thank you, Professor Tanaka, for your very kind introduction. Good afternoon, ladies and gentlemen. It's my great honor and pleasure to be part of this very important HCV policies forum, which I think a lot of things have been done, but still a lot we have to do. So I will be quite focused on some work that we have been doing in Hong Kong to how to manage some quite difficult to manage people who use drugs. Some of my disclosures. we repeatedly see this very important slides that hepatitis, chronic viral hepatitis still kills a lot of people. So over the last nearly 10 years, we have been working very hard to reach these goals. So I would say that now probably half the time, like 7, 8 years have gone, and we still have another like 6 years to reach the time point of year 2030. That what we have been doing and any other things we have to do. So in fact, our government in Hong Kong, we have been like very closely monitor our achievement with some benchmark, focusing on the hepatitis C things like the diagnosis rate, treatment coverage. I would say that we're kind of doing quite reasonably well because the cohort of patients with chronic hepatitis C in Hong Kong is not that large compared to Hep B. So that's why I think we are kind of past our midterm assessment, you may say, that we are setting the targets that by 2025, we are almost like surpassing a little bit. But I also have to highlight that to achieve to the goal set by year 2030, even is a small part, but usually these will be the most difficult, challenging parts, that how can we further improve our diagnosis rate and treatment coverage? So what things we can do better in the coming few years? So we keep learning from some excellence model around the world. This is one good model from the UK. They use this rapid point of care test as well as a very short course DAA. So just now, I think Dr. Easterbrook also highlighted that, in fact, point of care test is something very helpful to streamline the assessment, and then we can start the treatment right away, right at the spot. So this is something that this is from Australia, that this model have been working very well, that in fact, the treatment uptake rate can be very high as 92%. And this is something that we are learning. So in Hong Kong, we have this program. In fact, it started quite a while ago, since year 2009, which at that time we only had PAC-RIBA, but we at that time, we started this program aiming to increase the screening rate. So that's why we partnered with some NGOs in Hong Kong. We access to people. In the old days, we focused on those already quit using drugs, but in more recent years, we also included active users. So we keep doing workshop, education program, and in fact, in parallel, while we are giving talks, next door, our colleagues will do the finger prick test. In the old days, we only did the anti-HCV, but in more recent years, we also use a gene expert to also assess the HCV RNA level right at the spot. And I also highlighted in Hong Kong, our government set up the steering committee on prevention and control of viral hepatitis in year 2018, which is a while after the WHO call for hepatitis elimination. So we included a group of experts, high officials, that hopefully we can gather some good brains to set up a very good strategy apply locally. So like, for example, two of my mentors, Professor Henry Chen and Professor Vincent Wong, they are the members of the steering committee. And down this steering committee, we also have some working groups, like myself and Vincent. We are also the members of the clinical working group. We will set some actions that we can really work better at different levels, screening, management, linkage to care, and so on. So that's why how we try to put some efforts forward. So this is an old photo. So you see people still wearing masks that time, because it was in year 2020. That was the first year of COVID outbreak. But at that time, our government took this efforts to have this Hong Kong viral hepatitis action plan, which covered the last 5 years. So in fact, another action plan will be available very soon. I think that was the time point that we expanded our treatment coverage to all patients with detectable HCV RNA. They will be eligible for DAA treatment, fully funded, fully covered. So I think that time was a big step forward for managing patients with HCV. And this is the model that we adopted from very similar to the Australian model, that we use this test and treat pilot program. So the whole process just takes like one morning. So, but I have to highlight, we need a lot of effort from our social workers, our NGOs partners. They gather the people, like a group of 8 to 10. They come together to our center. So we on one spot, we would do the finger prick test to have the gene experts, which runs for like 15 minutes. And then at the same time, they will watch some video, and also we do fibroscan on them. So we can have all the steps streamlined within like a couple of hours. When the HCV RNA results available, then we can start the DA treatment right at the spot. So everything can be finished within one morning. So I think with this very streamlined program, in fact, we successfully treat quite a handful of patients because we can do everything at the same spot. So at the same time, we also have another model is a fast track HCV clinic, which may not everything happen in the one morning, but still we will accept some referral that they have either positive HCV RNA or anti-HCV. Then we will refer to the patients to our clinic within like a couple of weeks. And then we try to also skip a few steps that measure the blood test as well as do follow-up scan within a very short period of time. And then we start the treatment very soon. So I think these two models also try to improve the treatment uptake rates and also the decrease the rate lost to follow-up. So over the last 1.5 years, we partnered with some of our sister hospitals around our region, as well as some direct referrals from NGOs. Then at the end of the day, you can see the last 3 rows that in fact, among those patients with detectable HCV RNA, in fact, the number of referral, treatment uptake rate, and treatment success rate is very high. So which is in fact much higher than this program started before. So which means that in fact with this streamlined approaches, we can hardly improve the DAA treatment uptake rate as well as this treatment success rate. So this very short presentation share with you some of our current practices. So definitely we wish to do more. Example, those who not yet diagnosed, hopefully we can further improve the diagnosis rate. So I would also love to share with you this website. In fact, it's one of the platforms that we educate our public, general public, or any people who are interested in liver diseases. So in fact, just if you come across someone who can read Chinese, feel free to visit these websites. We have a lot of articles about HCV as well as other liver diseases. So with that, I thank you very much for your attention.
So thank you very much. The question is, okay, after that. Okay, thank you very much. So next speaker is Professor Yanko. He's a senior consultant, Department of Gastroenterology Hepatology, Tan Torak Sang Hospital, Singapore. So, okay, please start.
Thank you, Professor Tanaka, for your kind introduction. I'm Guo Chao-Yu from the Tan Torak Seng Hospital, Singapore. So today, I thank you to the Apostle and also the Global Task Force for your invitation to talk about simplification of hepatitis C care in Singapore. I would like to share with you some of the insight that I can gather from the Educate, Test and Treat program. So this is my disclosure. So if you look at how we actually molding outreach program, and every nation or every district of nation would have some issues with how to actually design the model. So essentially, I come across this systematic review and meta-analysis is actually rather comprehensive and interesting. It's actually helpful. And we can see that barrier exists in every segment of the Hep C care cascade, inclusive of patient, the provider, and also the system. So many studies are actually focusing on the antibody testing and also linkage to care as well. You can see here, but there's actually also some subdivision in terms of all this, the care of cascade there. So to ensure that Hep C eliminations is a successful program, all these elements must be taken care of. However, we always come revolving around the issues of the budget limitation. We have to actually plan our program very well and very carefully and see which component in the cascade of care is actually important for us to actually invest the money in and also the time. So as well, you can see here, the integrated care coordination, and also patients' education are critical for success. And sometimes the DBS, the dry blood test system service, and also the POC testing could improve the HCV testing. And there's actually evidence actually lacking for finance incentive to the PV group. So this is a busy slide, but I try to actually simplify it for you. If let's say you can actually follow what is a component that's actually the significant, would actually ensure the success of your program is antibody testing, which must have a multiple component, point-of-care antibody, and also on-site swab collection sometimes, and also opt-out screening. And if let's say you look at the linkage of care, then the provider care system and also telehealth would actually have some impact. So there's many interventions that could be beneficial in each care cascade component, and the specific interventions are more efficient than the other. So what have I learned from this journey of the PV in Singapore, who's actually released from the drug rehabilitation center, going through the in-care, pre-release, after-care, and reintegration, through the educate, test, and treat program, in which is actually at the reintegration of the inmate back to the society, when they are residing in the halfway house. We started off the program back in 2022. Then after we have a launch, then we decided actually to do a validation test in the POCT to ensure that what we are going to actually upskill is actually really something reliable. Then along the process that we gather the correlation of effort from all the other halfway houses who's actually willing to actually, to look into this Hep C, the problem in the PV group. So to summarize, what we are doing here is actually the ETT program have an outreach for program participation, in which we actually managed to actually have a collaboration between the 5 major halfway houses in Singapore. And however, it's still at the opt-in testing at the moment. The Hep C testing, we evaluate the point of care testing using oral saliva for Hep C antibody, because we foresee that in case that we need to actually decentralize the model, then we hope that this oral saliva testing can be actually led by the halfway house personnel, which is actually non-medical. And if actually you rely on the finger prick, the services, because there's actually concerns of infection. So you probably need to actually allocate a healthcare personnel to actually go down to the halfway houses. So in Singapore, we have at least 10 to 15 halfway houses, big and small. So the question is actually how are you actually going to sustain it, and how are you going to actually do a periodical kind of testing? All this is actually important to be part of the consideration. So we also educate the educational brochure, and I'll show you the few components example after this. To actually guide the PV group on their treatment and also disease treatment journey. And we also hope that actually it can be a peer guidance approach. And we are going to train the halfway houses personnel to actually guide the newcomer on this, Hep C elimination program. So we have an ETT care coordinator, in which they try to actually engage and then also facilitate the appointment and also the final application, linkage to care through telehealth, and also some participation on general practitioner and the treatment initiation, and with some provider care coordination, in which I go into detail later, and also rely on the FIT4 pre-screening rather than only fibroscan screening, and also the finance incentive that we actually try to actually get the support for the medical cost on DA treatment. So the first question is actually whether the POCT using the saliva is actually comparable to the venous blood testing or the finger prick testing. So we went down to halfway houses every 2 weeks, then to recruit about 10 to 15 patients, and managed to actually come to the sample size of 210 patients, approximately 210. And we finally able to analyze 207, and the average age is actually 53 years old. And most of them are males, mostly is Chinese, and some of them are the residents, and some of them are the alumni. So we compare the blood tests, the performance to the saliva testing, and also the finger prick with the blood test. So this is what we found. So the saliva test, even though it's actually very conducive, but however, if you look at when we actually move from one halfway house to the other halfway houses, then there's actually some disparity between the performance of finger prick tests and also the saliva test. We decided to actually look at this in the further detail. It's actually because if you look at the sub-analysis of 103 patients, the first halfway house in which we have more control to actually ensure them to actually have a 30 minutes of no food and also no drinks. And we are actually able to achieve 77.5% of the performance, which is actually a little bit lower than the reported literature rate, sometimes actually between 85 to 95%. So collectively, there's some significant differences between the finger prick and also the oral saliva tests, in which finger prick will give you 81% and 74% by the oral fluid. And the insight from here is actually for the other Harvey houses, like Harvey houses 2, 3, and 4, we actually all rely on this patient self-reporting. Whether you have fasted for 30 minutes, then we actually perform the test straight away because of the logistic issue. So there is some variation in the oral fluid and oral pathology, such as mucositis or the collection methods, which actually may impact the POC results. And apart from the choosing a right testing, we also have to actually look at what is actually, the way to actually go by the conventional pathway. In Singapore, to get a subsidiary pathway, you need to actually get a referral from a polyclinic and also a trust clinic. And after that, you get a referral to the hospital, the clinic, in which with some waiting time. So all this could take up to 12 weeks. So we actually collaborate with a trust GP, in which we have a POC test performance and which have verified the result through the telehealth, because a verification for HCV POC still need the healthcare personnel at the moment. And after that, if let's say test positive, then on site the GP will refer to the hospital clinic, and this we managed to actually cut it down to about 2 weeks. So we also rely on the FIT4 because from the learning cycle, we noticed that to wait for the FibroScan to give us the results of the advanced fibrosis is actually too long for us. And then we noticed that the longer time of the waiting time, the more patients will fall out from the system. So we try to actually adopt the ASLD guidelines in terms of utilizing the FIT4 to actually screen through the those actually without the advanced fibrosis. And we coordinate for those actually at the indeterminate and also the advanced fibrosis stage to actually have a FibroScan confirmation later. But this doesn't impede the referral pathway to initiate the DAA. And as well, you can see here also, because we need to actually go through a lot of finance application in terms of the eligibility to get the subsidy from the government for the DAA. So that's why we also actually partnered with the charity association to simplify the application process to get them to start the DAA, and we are able to manage to actually cut down the waiting time to about 6 weeks from the time with a POC positive. So there is some fine coordination in the integrated care in between the conventional pathway and also simplification pathway. So as well, you can see here, if let's say it's a test positive at the background, the patients come to us at the first visit, we'll calculate the FIT4, we evaluate whether there's actually a need to actually treat the viremia. And if let's say there's actually a need then we actually will contact back to the Harvest House coordinator, who actually will initiate the application to the charity fund for finance assistance. And this actually will take typically about 1 to 2 weeks. And after that, with approval, they inform us, then there's actually a coordination between the clinician and also the pharmacist to get the medication ready. So with this, we have managed to actually reduce the overall waiting time of 22 weeks down to the waiting time about 5 to 6 weeks from here. So this is actually a summary of what we do. In terms of visit, there's actually at least 11 steps for the visit for the patient in terms of the activity to get the DAA, to get DAA, the treatment and also the SVR. However, with remodeling, we are actually able to actually slash down to about 4 visits if actually that's actually feasible through some integrated care, some collaboration, and also some telehealth technology. So as an example, the patient education by the peers, we hope that we already developed this brochure. And in this brochure, we have some program on the transport incentive. There's a peer support, elements inside. And we actually educate the halfway house personnel to actually understand the natural history so that they can disseminate the knowledge to the inmates. And also we tell them that this POCT performance, what is actually outcome from our evaluation in our ETT phase 1, the performance of the oral quick POC test. And after that, of course, it's not a perfect test. So there's actually some risk mitigation. If let's say they feel that really they are at risk, they want to know 100% for sure, then we still have the pathway for them to actually go to the trust clinic to actually have the proper test done. So I will also lastly want to highlight this role of a care coordinator and also befriender, because for this marginalized underserved group, they are very frightened, or they feel they're stigmatized to actually come to the hospital. They need to actually hold hand with a befriender or a care coordinator. And I have I'd like to have Larry Sogiago to come. He's actually have a Hep C infections before. He went through a journey. He understand about the experience and also the hurdles of to get a Hep C treatment done. So he's actually in the best place to actually to become a care coordinator and also befriender. So if I want to actually critically appraise the educate, test, and treat program, which is actually looks like that, no, I mean, we're actually planning to actually upskill, hopefully to get the blessing from the government, the policy through the help from the senior. We probably can actually, apply some of the knowledge that we learned from this ETT small model and see what we can do better. But as well, I can appraise here is actually on track on the antibody testing and the first part, and the linkage to care and also the treatment initiation. We still need to do a lot of other work. So in conclusion, simplification of a Hep C care cascade would enhance the uptake of the Hep C elimination program, and this is essential for cost saving, prevention of attrition in the care, and also sustainability of the program. So this could happen in the cascade of POC testing using all level, care coordination, hospital navigation, finance reimbursement, application, clinic visit for the Hep C treatment journey. However, there's still some challenges in ETT program. It remains exemplified by the diagnosis performance of the test we choose in terms of the acceptability and also the practicability, and also the special needs of the undeserved group, and also the budget allocation for the treatment. Thank you very much.
Thank you very much. Please come and take a seat here. So we have maybe 10 or something minutes for discussions about they give a talk about how to improve HCV care cascade. And it is a little bit difficult to, if they found so positive, but it is difficult to link to care. So especially for the PWID person. So is there any questions or some comments or others?
Fantastic presentations of really model programs. For Grace, what struck me was just how well is testing going to get those patients into those quality care systems that you were speaking of? And are there any particular incentives for clinicians to order the test or test routinely, automated as part of electronic medical records, or if there are other strategies to improve testing? And then I'll stop there. I'll start with you, Grace, first.
Great, thanks, John. Yeah, I will say that at this moment we are making it a kind of like pilot program, because we have some close partnership with our like NGO social workers. So for some of the doctors who have the experience working together with the NGOs, they're more willing to either provide some fast track referral, as well as they are also more willing to screen more patients that they perceive they have risk factors. And very recently, we also trying to expand the screening to some psychiatric patients. We also have close partnership with psychiatrists, especially those who have special interest on managing patients with substance abuses. And we also kind of already started a couple of years ago that we advocate them to essentially screen all patients to their clinics or to their wards that are those with risk factors of substance abuse. They also screen more Hep C. So that's why there are also more referral from that part. But I have to say that we still have a lot of podcasts not well screened. In fact, we wish to further expand to like probably all patients who have mental problems, either to the psychiatric clinics or hospital, but not every psychiatrist will share the same view. I think those with experience in substance abuse patient would be more willing, but for general psychiatric diseases, they are less willing. So I think probably we still need to have a lot of like actions or campaign to move forward to let them know their risk factors as well. Their risk profile is a bit higher than the general population. Then we can try to expand the screening program. Yeah, thank you.
Yeah. I mean, to that point, I wonder if perhaps you do this just to give feedback to that psychiatrist that, you know, their referral ended in a cure for their patient, et cetera. And maybe that continues to motivate.
That's very helpful. In fact, we have this feedback, either the patient have come and have successfully treated, or the other end would be some patient who didn't show up. We also feedback to the psychiatrist. And for those who defaulted, we keep asking the psychiatric nurses to keep chasing them back to hopefully link them to care on someday. Yeah, that's very helpful. Thank you.
Dr. Chow, and maybe Grace, also, I know in the United States, I asked this for Junko yesterday for Japan, there's a fairly high percentage of patients who get diagnosed but then don't get treated. And sometimes they refuse treatment or feel like it's, you know, not that important, or just because of the way the system is set up, they fall out of care. And so I was just wanting to get the experience from Singapore and then from Hong Kong about what's that level of acceptance after that diagnosis happens. Thank you.
Yeah. So the level of acceptance of Hep C, I mean, Prof, I have to actually say this is actually because if you actually diagnose them very early, they have no symptoms. They have others priorities in life. They are in the integration back to the society. And the way I look at it is actually, if let's say education on Hep C natural history is just not enough. You really need to actually engage with somebody from, I mean, the who actually went through. That's why my care coordinator is actually inside there. Explain why they should get it treated. And it have to actually come down to the actually peer support level. We did have a survey, and no, I think about 60% of them would actually accept the talk to the, I mean, with peers rather than with a healthcare personnel. We went through 2 years to develop this program. It's very bumpy. So along the way, I think we noticed that there's actually a high rate of attrition. And if let's say they perceive this as so important, and they will actually come forward to receive the treatment and also to get a consultation. And that is also the social aspect, which is actually very difficult, in which, like, for example, there are actually frontier, as what I presented before, that's actually is a front desk kind of work. Then they cannot leave their workstation so easily. Then you need to show them the notification to the employer. And there's actually some sensitivity. Then the employer asks them where are you going and everything. So it's actually rather tricky. But I should say that I think with the integrated care and also with the peer support, we can go there. We just need to show these models actually working. We need some more blessing from the political will, seniors to actually talk to the government to actually, give us more budget to actually upskill. Yeah. Thank you.
Thanks. Just a quick question.
Okay.
So very
Thank you very
nice
much.
and
Yeah.
inspiring presentations. I just wanted to get your perspectives on the emerging opportunity for the use of long-actings. And you may be aware that particularly focused on GP, that it's probably a couple of years away, but the potential for a long-acting, it could be 1 injection, it could be 2. So how would you see this as being a game changer or not? for your patient population. And I think it's particularly relevant to the disadvantaged, the homeless, the PWID who have difficulty coming back and adhering. Thanks.
Thank you so much. I think this is definitely would be something very helpful for a very special group of patients, which is particularly challenging at this moment. I would say that, like, also feedback a little bit to the previous questions, that the treatment uptake, the willingness to be treated at this moment is already quite high. I would say the current day regimens already cover probably more than 90 or 95% of patients. But I fully agree, some particularly challenging patients. I also come across some patients after being diagnosed to have active viremia, they still refuse to come back after multiple courses. So I think that probably because of their social issues, some would care about their work, their food, more than their chronic hepatitis C. So I think for those like homeless people, that you probably only can see them once in their whole life. I think this kind of long-acting agent would be very helpful to further push up the treatment uptake way. Yeah, thank you.
Okay.
Okay, thank you very much for a nice presentation. My name is Tatsuya Kanto from Japan. And I have a question to Yaku, and the Singapore system. Sorry for mispronunciation of your name, but anyway, I'm very impressed about the simplified method. That is a key strategy for enhancing the cascade care. And I think you explained the other part about the care coordinators in your country. But because in Japan, we have a similar education system for medical staff, hepatitis care coordinators to support patients and, of course, patient families to encourage and test and treat. And in your slide, I could have found that some kind of advice or support is reimbursed. Am I right? And because in Japan, working by the hepatitis care coordinators is not reimbursed because systematically. So I think that is a really important issue to encourage such kind of medical staff to get into the supporting activities. And of course, they're acknowledged about how important their work is. So I want to learn a little bit more about how and how have you accomplished in your country the reimbursement system for supporters?
Thank you for your excellent question. We have a struggle, and the struggle is still ongoing. The reimbursement, we call it as co-payment. So for out of 100% of the DAA cost, there's no generic in Singapore yet. So most of this PWID group will get 75% of the subsidy, and that for the leftover 25% is actually must bear by the PWID group. So the 25% is actually 1.8K Sing dollar at least. So this is a big sum to them. So for that, right? I think there's actually a pathway for the medical assistance fund approval, in which and also the Medifund approval, in which the patients actually need to actually submit document. And that document is actually per household document. It means that whoever actually sharing the same IC of your, under the same household, they need to provide their salary slip. And then during the interview and or something, this is actually where the problem is. It's actually because of the kind of background, the high risk background and the family dynamic, we cannot actually ensure that all the family members actually that supportive, and that's actually one of the critical areas that has actually caused the breakage in the linkage to care. So we have to actually move this forward. So we get we actually outreach to the charity organization, and which is actually very willing to help us. And that's actually what I can actually demonstrate inside the slide, that if let's say there's actually finance assistance that and on that path, we can actually very shorten it. And the finance application documents requirement is actually not that stringent as compared to the interview by the social worker. And we actually will actually also explore your habits of smoking. Smoking, and also why do you have money for smoking and no money actually to save for this DAA? So we are still in the process of discussion. because after the submission of collation of a document, you need to actually wait for the meeting, which is actually at a monthly or 2-monthly basis. So this is actually explain why there's actually a wait. And then during the wait is actually dangerous because they will fall out. Yeah. So so that's why the care coordinator, if they have a support, and then no, because we are at the medical site. I'm sorry, taking some time. We are at the medical site, and they are actually at the social side, then they'll be actually unable to actually see. The care coordinator is actually coming from the background that they know their family better than us. So that's why they are actually ambassador for us to actually to talk to the family, to collect the document, and to actually make sure that whatever is actually appropriate is actually submitted on time. Yeah. So this is actually what we're working towards too.
Okay, so what kind of occupational background do they have, the care coordinators? The most of the nurses or public health nurses, occupational background for the care coordinators in your country?
Oh,
Nurse?
so for these care coordinators, actually from the halfway house. It's not a healthcare personnel.
Okay.
Yeah.
All right, thank you.
Okay,
Yeah.
please.
I'm Dr. Chen from Taiwan. I have a question to Grace. I thank you very much for your wonderful presentation. As you know, if we want to reach the WHO HCV elimination, the major barrier is try to find out those HCV infected patients lost on awareness. So do you think we should do the nationwide HCV screen program to find out those unawareness of HCV infection?
Great, Professor Chen. I think, first of all, I would like to congratulate Taiwan has been doing a great job in terms of HCV screening and engagement management. I know many doctors in Taiwan, they also have some different kind of screening. They outreach to some relatively rural area, or I also come across some, like they see the chance of patient come to the diabetic clinics. They also do the automated screening, which I would say that at least in Hong Kong, because our prevalence is 0.3% for chronic hepatitis C. So I don't think our government will agree to do really a universal screening for everyone. Probably not. But I think we still have a few podcasts that we haven't have a very systematic screening. I would say that patients with mental illnesses or patients with even, I think diabetics is something that a very wise move because they are coming back for complication screening anyway. So we just add one more test for them, as well as some of the like very underprivileged people. In fact, those we know that their prevalence will be much higher. Like for example, homeless people, usually more than 10 to 20% of prevalence. So I think probably at least in Hong Kong, our government would prefer to focus their resources there. But I think can stepwise, and we can definitely go along with the existing data. Perhaps if the known prevalence is above certain threshold, we can definitely screen that population. Yeah, thank you.
Yeah, thank you. I also have a question to Dr. Zhao. Because point of care HCV testing is more cheaper by finger stick than the using saliva, but you choose saliva as a point of
Or
test.
cyber. Yeah.
Saliva, point of care. So why do you
Yeah,
do you why don't you choose the point of care testing by finger stick?
Okay, it have to depends on which type of finger prick test, which brand are we using. So in our project we use Oral Quick. We actually really want to actually see the saliva. The things about saliva test is actually you really have to actually have experience to hold the stick and ask the patient to do it in front of you and follow through the procedure. Then you can actually really appreciate how simple it is. And it is just fall short of their performance of sensitivity, and it's actually antibody tests. I do agree that there's a limitation, but however, the saliva test is actually, they're so easy until, even the WHO is actually promoting self-testing. So there's actually no reason why the halfway houses, the staff won't be able to actually test, using this. So at the periodical basis to actually check for the prevalence of the antibody. So I think saliva test is very inviting. And we have a survey of feedback to say that if let's say compare the finger prick, venous blood, and also the saliva, which one you would prefer? If let's say somebody performed to you, then you can see my slides actually is quite heterogeneous. But when we actually revert, the question is actually, if you want to actually perform yourself, which one will you prefer? Then everybody will choose the saliva test. Yeah.
Thank you.
Okay, so, okay, thank you very much for great discussions. So the presenters bring a fast track program to improve linkage of care. So we have to consider about this. Thank you very much. Thank you very much. Oh, so we will take a break and John suggests to.
We'd love to get a photo of everyone, as we traditionally do here at these forums. So before we break, if everybody could come forward for a quick photo, I would greatly appreciate it.
What time?
And then we will come back at 30 minutes after the hour for our break. So please
Okay.
come forward for a photo right in front of the stage.
Yeah, okay.
And
5 minutes before starting.
yeah,
Or
well,
not,
we're
or
gonna
not?
do it right now.
Okay, right.
We're gonna
now.
do it
Okay,
right.
we are
Let's
right
go ahead
now.
and have the
Okay.
photo right
Yeah,
now
right.
while we have everybody's
Okay.
attention. Thank you.
Thank you very much, the lecturer and the moderators.
Here is the mouse, but that's not work.
Okay, everyone, let's restart the program, please. For those in the hallway, please come back in. And we'll have my a colleague, Professor MLU from the National Sun Yat-sen University of Taiwan, come and moderate our next session.